Yeah, right.
Good evening, everyone. Welcome to iFocus Online, Lecture 204 and Retina Session 56. And this happens to be a masterclass. Now that we have learned about retinal reattachment, I think it's time for us to know about the retinal reattachment bit by Dr. Lingam Gopal, sir. And he'll be talking on the general surgical principles, scleral buckling, and pneumatic retinopexy. I request Dr. Lalit Verma, sir, to please introduce Dr. Lingam Gopal.
Thank you, Rolika. LG sir does not require much of introduction because he's a household name, at least amongst the retina circles and amongst the ophthalmologists in India. I would describe him as a doyen in the field of retina and one of the finest surgeons this country has, and with very, I should say, ultra clear concepts on the pathogenesis of various retinal disorders. And it's our proud privilege, and I, on behalf of the entire iFocus team as well as Center for Sight team, welcome you, sir, to this unique program of iFocus, wherein we have modules of teaching for the PG students primarily and anybody interested in learning. In the past couple of sessions, we have discussed about retinal attachment and the principles of retinal detachment and principles of reg RD also. And today, LG sir will be telling us about the principles of reattachment. General principles with the thrust on buckling as well as PR, pneumoretinopexy. As the slide shows, he has huge number of orations. I'm not going to read all the named orations. I think this half of the slide is of these named orations. But very important is that he is a master, in all these retinal disorders, and he has chief interest in ROP also. Has published, you see, over 200 papers with over 32 chapters, and has been, as a guest faculty with 330 lectures to his credit. His post-graduation, I know, was done in Chandigarh. After that, he has had to his credit DNB as well as FRC, and presently he is at Sankara Nethralaya as well as a senior consultant at NUHS Singapore. So over to LG sir, you can start sharing your slide. You have a good 45-50 minutes with you. After that, we'll take some questions for discussion by the hot seats. Yeah, we can see yours.
At the outset, I would like to thank Dr. Santosh, Dr. Lalit Verma, for having given this opportunity for me to talk about this subject, which is very dear to our hearts. Since I was not aware of the previous lectures, there may be a little bit of overlap between the previous lectures and this one, but I don't think it's a waste of time because it re-emphasizes some concepts about why retinal detachment takes place and etc. So I would like to apologize in advance if there is too much of overlap with the previous talks, but finally I'll be talking mainly on pneumatic retinopexy and scleral buckling. So this is the outline I just made so that people know what I'm going to talk in advance. So first, let us talk about what keeps the retina attached normally before we understand why it detaches in a pathological situation. We know that the neurosensory retina separates from the retinal pigment epithelium. That's what we call as retinal detachment. And we also know that this is as if the space in the primordial vesicle has got reopened now when the retina got detached. So the factors that keep the retina normally attached are various, including the vitreous support itself. So it's not that vitreous gel is redundant, like appendix. People think that you can remove it and get away with it. But actually it serves a very important purpose. It's only when it is diseased that we remove it, not when it is normal. So an intact gel vitreous has a mechanical tamponading effect on the retina, but removal of the vitreous does not necessarily detach the retina because of other reasons why the retina remains attached. So in the presence of a retinal break, an intact gel can actually tamponade the break very well. But when the vitreous is synergetic, it increases the tendency for the retina to detach. So in fact, in the concept of scleral buckling, we try to push the hole against the vitreous gel so that the tamponading effect of the vitreous gel is taken into consideration. In a non-rhegmatogenous retinal detachment, however, even the vitreous gel is intact, and still the retina can detach because it is because of fluid being pushed, fluid pushing the retina forwards. So another important factor that keeps the retina attached normally is the fluid pressure, be it osmotic or hydrostatic. It drives the fluid passively from the vitreous towards the choroid and has a pressure gradient of about 12 millimeters of mercury. So the normal resistance to this flow is by the retina and the pigment epithelium, and this is what keeps the retina pushed against the RPE. Under abnormal conditions, when the retina is detached, the RPE pump can actually pump at the rate of 0.3 microliters per hour per millimeters, almost 3.5 milliliters per day, which is why if you seal a retinal break with a pneumatic retinopexy, you will find the next day even a bullous retinal detachment can totally flatten because it can be pumped out by an efficient retinal pigment epithelial pump. There are also mechanical forces which try to keep the retina in place in the subretinal space. The interdigitation between retinal pigment epithelial microvilli and the tips of the outer segment photoreceptors. This is caused both by the mechanical force due to the indentation caused by the microvilli and the close ensheathment between the villi and the photoreceptors, also by the electrostatic forces that oppose the separation of these membranes. The interphotoreceptor matrix also has a glue-like effect that tries to keep the retina attached to the retinal pigment epithelium. There are metabolic forces as well, possibly act by modulating the fluid absorption by retinal pigment epithelium. We know that usage of mannitol and acetazolamide as well as cold temperature can increase the retinal adhesion, while injecting an hyperosmotic agent like urea into the vitreous can actually loosen the adhesion. So once the retina is detached, what are the cellular effects on the retina? This is important for us to understand because this is a bearing on the proliferative vitreoretinopathy, etc. So the retinal pigment epithelium is altered by its apical surface, and there's proliferation of RPE cells which can be self-limiting, and then there's migration of the RPE cells through the break into the vitreous cavity where it settles on mainly on the inferior part of the fundus, and that's why PVR is more significant inferiorly. But there's an excellent study at Baltimore where they have shown that if you turn a rabbit or a monkey where the RPE cells are injected in another direction, whichever is a dependent position is where the PVR occurs most. So it is the dependency, gravity-driven settlement of RPE cells inferiorly that causes the inferior PVR more often. The photoreceptors also undergo an outer segment degeneration, and the subretinal space has neutrophils, mononucleocytes, and macrophages, as well as free RPE cells and outer segment fragments that are present in the subretinal space. Some problem. Okay. So the other cellular effects of retinal detachment are the photoreceptor degeneration. This is important for us to understand because this is what is the reason why the visual recovery changes depending upon how long the macula is detached. And peripheral retina obviously also takes time to recover once the retina is reattached. So we all know that in the anatomy of the photoreceptors, the outer segment is what has the discs, while the inner segment is containing the mitochondria in the ellipsoid zone and the Golgi bodies in the myoid zone. The inner segment undergoes swelling and disruption with the loss of the mitochondria, and hence the ellipsoid zone tends to get lost. But the connecting filament is retained. The cone outer segment protein production stops within 1 week of occurrence of detachment, and photoreceptor cell apoptosis continues to take place after retinal detachment has occurred, although it peaks at day 2, it keeps on taking place. This results in cell death and extrusion of the cell bodies into the subretinal space. There's also effect on other retinal cells, including the rod bipolar cells. And these retinal bipolar cell processes may actually grow beyond the photoreceptor layer into subretinal space. And that can actually make it difficult for the retina to recover even after retina is reattached, because these bipolar cell processes do not permit the photoreceptor cells to get integrated with the RPE cells. Ganglion cells tend to re-express the growth associated protein factor 43, and non-neuronal cells such as astrocytes, Mueller cells, pericytes, etc. also tend to show signs of proliferation. This is what leads to gliosis. And Mueller cell processes preferentially express the vimentin and CD44 and can reach the subretinal space and grow on the photoreceptor surface. These are all the changes which occur over time. So the longer the retina is detached, more are these changes which make the retina less functional over a period of time. And once you reattach the retina, you should understand the trigger factor for PVR is not totally eliminated. Even when the retina is reattached, there may still be persistent trigger factor for PVR, and hence scarring can still take place in redetach and attached retina. The recovery also involves redifferentiation of the surface of the RPE cells, establishment of a contact between the RPE cells and photoreceptors, synthesis of interphotoreceptor matrix, and re-establishment of the balance between photoreceptor disc adhesion and its shedding. All this process takes time, and it may take several months or even years for it to stabilize. And hence, just because you reattach the retina, visual recovery doesn't start next day. Although it can start, it reaches a plateau only after a period of time. And hence, up to 6 months it may take for final vision to be acquired after reattachment of retina. Now, broadly, this is what is the pathogenesis and pathology of retinal detachment. Let's talk about the types of retinal detachment. Broadly, is rhegmatogenous, tractional, combined rhegmatogenous detachment, and exudative or secondary retinal detachments. The rhegma is what defines the retinal detachment which we manage surgically. Not that you don't manage surgically tractional detachment, but in this particular lecture, I'm going to talk about primary rhegmatogenous retinal detachment. So the rhegma has been defined by Gonin, who actually defined the fact that it is the rhegma which causes the detachment and not the detachment which causes the rhegma. Because before him, people thought the highly elevated retina is pushing the retina and is tearing it. So they thought the retinal break occurs after retinal detachment, but not the cause of detachment. So we know that the holes that can lead to retinal detachment could be retinal tears, which are usually caused by vitreous traction, or they can be atrophic retinal holes inside a lattice degeneration, or they can be operculated retinal breaks where the traction has got relieved and the operculum is free floating in the vitreous cavity, but primarily this hole is also caused by vitreous traction. So in the tractional tears, they occur at the vitreous base following a PVD. They can also occur at the edge of strong attachments such as choroidal scars, or at the edge of lattice degenerations, where again you can get a traction tear, while within the middle of lattice you get atrophic holes. They can occur along major blood vessels. Retinal tears can occur like slit tears, which very often are what is seen in highly myopic eyes in the posterior pole, and they can be easily missed because they are slit-like next to a retinal major vessel. They can occur in necrotic areas of infectious retinitis or at the edge of a patch of healed retinitis. Retinoschisis related breaks can occur both in the outer layer and inner layer because of extreme thinning of the retina. It's the outer layer which is more important in terms of leading to a rhegmatogenous clinical detachment, where inner layer does not lead to retinal detachment in retinoschisis. Posterior pole breaks are more often seen in the macular area as a macular hole, but they can also be seen along blood vessels and or atrophic areas, specifically in cases of high myopia associated with posterior cephaloma. These two pictures just try to show you the various breaks, some of the breaks that have been described just now. I'm not able to use the pointer. Not sure why, but you should be able to see in the picture up and left the horseshoe tear in the lower nasal quadrant with a flap which is floating up. There are multiple patches of lattice, both inferior nasally, inferior temporally, and right temporally at 3 o'clock meridian. In the picture to your right, there is a small retinal tear. Again, I'm having difficulty because it is superimposed by some of the pictures in the Zoom, so I'm not able to show you. But there is a small tiny tear at 3 o'clock meridian. Giant retinal breaks is a term used to describe tears which are more than 90 degrees circumferentially. One has to differentiate between giant retinal tear and giant retinal dialysis. A retinal tear is a split at the posterior vitreous base, and hence the anterior to the vitreous base, there is still retina attached to the vitreous. while in a giant retinal dialysis, the split is at the ora serrata, and hence anterior to the split is a ciliary epithelium and not retina. In a giant retinal tear, PVD is present, while in a fresh giant retinal dialysis, there is no PVD, and hence the retinal detachment takes some time before after the vitreous undergoes liquefied. So the vitreous base actually straddles the dialysis, while in giant retinal tear, the vitreous is attached entirely to the anterior flap, and posteriorly there is no vitreous at all. Usually the retinal detachment is very rapidly progressive in giant retinal tear, while in a dialysis it is slowly progressive based on the amount of vitreous that is liquefied. Symptoms, I won't dwell much in detail, but I want to just stress on the fact that retinal detachment can remain asymptomatic under certain circumstances. A retinal detachment occurring in amblyopic eye, already poor vision, so the patient may not be aware of further drop in vision, while localized retinal detachment in the periphery, like in lattice with holes or following a retinal dialysis, can also remain asymptomatic till they are accidentally discovered on examination or when it encroaches the macula. Again, retinal detachment in young children or mentally challenged patients can also go unrecognized unless they are bilaterally blind. Now coming to the management of simple retinal detachments. I said simple because I'm not going to talk about detachments which require vitreoretinal surgical approaches. Here we are talking about simple retinal detachments, and these can also be managed by vitreoretinal approaches, but I'm going to restrict my talk to scleral buckling and pneumatic retinopexy. So before we manage, first let us talk about, is it retinal detachment? Because the people have operated on conditions which are not really retinal detachment, but there's things like retinoschisis, Berlin's edema, choroidal detachment, even thick vitreous membranes and altered blood can mimic retinal detachment. So first you should be clear that you're indeed managing retinal detachment and not something else. And once you see it is retinal detachment, then you should first identify, is it a rhegmatogenous retinal detachment or it is the other two which I mentioned, TRD and exudative RD. Situation can be confusing in a post-inflammatory exudative RD because the retinal detachment need not be exactly like what you expect in exudative RD. RD secondary to tumors and uveal effusion syndromes. The caveats are a rhegmatogenous retinal detachment can occur in a post-inflammatory situation. Somebody with uveitis has been treated, the vitreous undergoes also some amount of condensation, and the traction can precipitate an eye, a retinal break and a detachment in an eye which is susceptible to such retinal detachments. So the starting point was the inflammation, vitreous debris, vitreous membranes, but then you can develop a rhegmatogenous retinal detachment as well. So that can be confusing. Then you can actually confuse it with an exudative RD because the vitreous also is hazy, you can't see the break easily, and you continue to treat with steroids with no response. What you need is actually surgery. Likewise, tumors can secondarily produce RRD, like a retinoblastoma can produce exudative RD to start with. But once it is treated, there's also some amount of fibrosis, and this can cause, and also necrosis due to cryotherapy or laser, etc. This can cause secondary rhegmatogenous retinal detachment, at which stage, unfortunately, you have to operate and treat the condition rather than continue to treat with chemotherapy. So this slide gives you an overview as to differentiating between rhegmatogenous detachment, TRD, and exudative RD. I just want to stress that the configuration is convex towards the observer in both TRD, RRD and exudative RD, while in TRD, it is concave towards the observer because a force is pulling the retina towards you, but the RPE pump is trying to keep the retina back, so it becomes concave. The margins of RD are well defined in TRD because it's slowly progressive. It's ill-defined in both exudative and rhegmatogenous retinal detachment, with exceptions to rule being a slowly progressive RD, which can have well-defined margins. A retinal break is definitely seen in RRD, while a TRD can get converted into a combined RD with the development of retinal break. Characteristic of RRD is retinal undulations because of the retinal edema, which goes with acute RD. But once the RD becomes chronic, like in a lattice with holes, etc., you may not see retinal undulations, can actually misdiagnose it as a secondary RD. Shifting fluid is almost always seen in exudative RD and very rarely seen in RRD, but never in TRD. Pigment in the anterior vitreous cavity gives you a different indicator that retina is broken. That's why the RP cells migrated into the vitreous cavity. Other features which can help you have the presence of PVR, etc., and presence of evidence of tumor or uveitis, which shift to diagnosis towards exudative RD. So now coming to the management, first we need to locate the break. So Harvey-Linkoff has given us certain guidelines as to where to look for to identify a retinal break. A large break anybody can identify. Tiny breaks in the presence of a hazy media, early cataract, little bit of vitreous hemorrhage can make it difficult for us to locate a break. That is where Linkoff's rules will be very, very useful. So if you have a superior nasal or superior temporal detachment, in 98% of the times, the primary break lies within 1.5 clock hours of the highest border, as shown in the middle drawing. In the drawing to the left, I'm showing the first rule, which is when there's total or superior detachment that crosses the 12 o'clock meridian. In 93% of the cases, the break lies in a triangle defined by the apex being at the ora serrata and the sides interacting to 1 clock hour on either side of the 12 o'clock meridian. You know, 1 clock hour is about 30 degrees. So 30 degrees on either side of the 12 o'clock meridian, it stretches this triangle. So the break lies within this 12 o'clock, within this triangle. So you spend all your energy in this area where you're likely to locate the break. The third situation is the inferior detachments, where in 95% of situations, the break lies on the side where the RD is higher, intuitive and logical. So nothing specific about Linkoff. It is just that Linkoff could identify that this is a logical way of looking at retinal break. So the approaches to fix the retina in a simple detachment can be barrage laser, where the fluid is less than 4 disc diameters in size approximately. Then you can do a barrage laser without doing a major surgery, understanding that the detachment itself will still remain as a detachment. You're only trying to barricade it so it doesn't spread beyond the barrage laser. But when it starts going beyond the barrage laser, you have to do surgical approach to fix the retina. Also, you should not be too enthusiastic to do barrage lasers by putting 4 or 5 rows, because the more you treat, the more the field effect will be for the patient. And if it is in a sensitive area, the patient will appreciate the field effect. Like a superior detachment, if you do barrage laser, the inferior field effect will be very much obvious to the patient. While the superior field effect is not that obvious, because in routine life, we don't look up as often as we look down. And you don't barrage laser right up to the arcade. That means your indication for barrage laser is wrong. Okay. Pneumatic retinopexy and scleral buckling are what I'm going to cover. Primary vitrectomy can also be used to fix a simple detachment in selected cases. So pneumatic retinopexy has been popularized by George Hilton. I use the word popularized because it was not invented by him. It was actually invented by somebody in Argentina who used air, but it is popularized by George Hilton. So the principle of pneumatic retinopexy is that gas has a buoyancy, so it floats. And gas bubble also has a surface tension, which is excellent. And this bridges across breaks, producing a tamponading effect, because it cuts off the convection currents of fluid from reaching the subretinal space, because it bridges across the retinal break. So the fluid entry into subretinal space is cut off. And once that is cut off, subretinal fluid gets absorbed by the RPE pump. Then laser or cryo can create a permanent adhesion on the break. So this is the basic principle of pneumatic retinopexy. And we know that surface tension is the same irrespective of what you use, whether it's air, C3F8, SF6, or C2F6. The surface tension property is same irrespective of what gas you use. It's just that the longevity of the gas is different, but the surface tension is the same. In fact, surface tension of silicone oil is much lower than that of gases. So the indication for pneumatic retinopexy is that 1 or more retinal breaks within 1 clock hour, that is about 30 degrees, located in the upper 8 clock hours, that is between 4 to 8 clock hours in the clock hour, with no PVR. And of course, you should be able to exclude other retinal breaks. If suppose there is a cataract which blocks the view of about 20% of the retina, or there is inferiorly vitreous hemorrhage which covers large part of the retina, you're not sure you have excluded a break there, then you should not try pneumatic retinopexy. And why 30 clock hours, 30 degrees or 1 clock hour is because an expanded gas bubble of C3F8 of 0.3 cc or a 0.5 cc of SF6 will roughly cover about 30 degrees of the fundus or 1 clock hour. So that is the maximum limit to which a pneumatic retinopexy can work. But usually we avoid treating if the break is so large as 30 degrees, for reasons I'll explain little later. So technique involves, if you're using cryopexy, you first do cryopexy and then inject gas. But if you're doing laser, you obviously inject gas first, let the retina reattach and then do laser, because you cannot do laser in a detached retina. Well, cryo you can still do in a detached retina. In fact, using cryopexy helps in softening the eye and enabling injection of the gas without too much worry about raised intraocular pressure. And then you sort of inject the gas bubble, either 0.5 cc of SF6 or 0.3 cc of C3F8. You do paracensis if needed. The technique for injection of gas is that you inject the gas by sticking the needle into the eye quite deep and then withdrawing it so that the needle tip lies approximately near the vitreous base, and then inject into the bubble. That means as you inject, the bubble should enlarge. While if you inject a quick thrust of the plunger, the bubbles shoot off from the tip and then ascend upwards into multiple small bubbles rather than being a single bubble. So very good technique is where you can withdraw the needle to right at the vitreous base and slowly inject so that further injection is occurring into the already injected bubble, which enlarges into a single bubble. It is easier said than done. In many cases, you don't succeed in getting a single bubble, but at least if you get 2 or 3 large bubbles, it's better than having multiple frog egg-like small bubbles. Then, of course, you posture the patient. Paracensis, if needed, based on the intraocular pressure at the end of injection procedure. You don't have to do paracensis first. You always inject the gas, wait for some time, and then do paracensis, depending on the requirement. A word about eyes with macula being attached at the time of pneumatic retinopexy. You should consider that the fluid takes time to get absorbed. So it's not going to get absorbed immediately. So as soon as you inject the bubble and the bubble goes and plugs the retinal brake, because the bubble occupies space and the fluid immediately tends to get pushed away from the area of the gas. So it tends to dissect into the macula, and you can actually induce a macular detachment when the macula was not detached to start with, which is not an ideal situation. Although the retina may get reattached the next day, we don't want to detach a macula which is already attached. So to avoid that, you use a steam roller technique, wherein you inject the gas bubble, quickly put the patient prone. So gas bubble goes to the macular area first, because you have put the patient prone. And once it is the macular area, you're safe. Now you try to slowly lift his patient's head, because you are doing a superior half of detachment. When you lift the patient's head slowly, while the patient is lying prone, the gas bubble is literally kneading or pushing against subretinal fluid and pushing the subretinal fluid towards the brake, because you are going to lift the head towards the meridian of the brake. And hence the fluid gets pushed through the brake into the vitreous cavity. And as the gas comes towards the brake, the retina is nearly attached, not totally attached, but nearly attached. So there's no bullous detachment, so no fluid to be squeezed towards the macular area. So you prevent a macular detachment. People have questioned this process, thinking that by squeezing the fluid into the vitreous cavity, you may also bring in a lot of RPE cells to the vitreous cavity and hence increase the risk of PVR. Well, that's a compromise or a trade-off between not avoiding a macular detachment and theoretically increasing slightly the risk of PVR. So this is the phenomenon of steamroller technique. So what are the complications of pneumatic retinopexy? The gas can be in the wrong place. It can be trapped in the petit space. You know, petit space is a potential space which is present between the posterior zonules of the lens and the anterior hyaloid face. So if your needle has not penetrated the vitreous properly, you can actually inject into the petit space, then it forms like a donut-shaped gas around the lens. There it doesn't serve any useful purpose, and tapping that gas can be extremely difficult and not easy. Another thing is that when you put the needle into the eye, if you remove the needle just like that, the whole gas, because the eye is now under high pressure, as soon as you complete the injection process, the gas bubble can come back through the sclerotomy into subconjunctival space. To avoid that, as soon as you inject, you don't withdraw the needle. You keep a cotton tip applicator right at the junction of the needle shaft to the sclera or conjunctiva, and then roll the cotton bud into place right over the sclerotomy as you are withdrawing the needle. So you plug the sclerotomy first. After you plug the sclerotomy, use the same cotton tip applicator to roll the eyeball so that that site of sclerotomy becomes the non-dependent position. I mean, more dependent position. So when it is more dependent position, the air or gas which you inject will shift away from the scleral hole through which you injected. And once it goes away, it has no tendency to escape from the eye, even if the intraocular pressure is high. So that's how you avoid subconjunctival leak of the gas. Again, subconjunctival leak, the gas in the subconjunctival space doesn't harm the eye, but it is useless there. You don't want the gas to be less in the quantity in the vitreous cavity. You don't want to lose that. So that's why it is a complication. Subretinal gas is a much more serious complication. That can happen when you have injected bubbles of gas, which are like frog eggs, and your break is rather large. So large breaks, even if it's not necessarily 30 degrees, but even if it is smaller but relatively large break, there's a risk that the gas bubbles can go into subretinal space. If they go into subretinal space, they're expanding in the wrong location. When they're expanding in the wrong location, they will never allow the retina to reattach, RP pump or no RP pump. So you have to do a vitrectomy in such cases, remove the subretinal gas and reattach the retina. Secondary glaucoma is a risk, and hence you do not inject this in patients with known glaucoma with a compromised optic disc. You don't want to make it worse by your injection process. And macular detachment in eyes with attached macula is also a risk complication following pneumatic retinopexy. But why does pneumatic retinopexy fail? Mostly because of a wrong choice of case. Very often people tend to do pneumatic retinopexy because they are hard pressed for time. They don't want to do scleral buckling. You say, okay, let's gain some time. I'll do pneumatic retinopexy. If it fails, I can always do a surgery. So that is a very, very wrong indication. Just because you don't have time to do a major surgery, you should not put the patient to pneumatic retinopexy. So it fails mainly because of a wrong choice of case. Missed break because you see one large break, you think you have seen everything. What is important is, even if you see a large break, you examine the rest of the retina very diligently to make sure there is no other tiny break. For every large break, there can be 100 smaller breaks which are hidden somewhere else. So you have to clearly examine and exclude another break in the rest of the retina. And if you're not able to examine the rest of the retina properly because of reasons I explained, like a cataract or vitreous hemorrhage or non-dilating pupil, then that's not the ideal case for pneumatic retinopexy. Relatively large breaks, I already alluded to, the risk of gas migrating to subretinal space. Again, inability for the patient to posture properly. That you have to assess pre-injection itself. Because once you inject and the patient is not able to position properly, the gas doesn't no good because it's not properly supporting the break. Poor technique, which can result in the gas leaking out in subconjunctival space or gas in the wrong location. New breaks has been described initially that the vitreous gel gets pushed up and hence it can cause breaks inferiorly. But that's probably not that common, although that's been described initially when the pneumatic retinopexy was described. Coming to scleral buckling, two people you definitely need to remember are Ernst Custodis and Charles Kippens. Custodis described the technique, which we adopt now, and Charles Kippens described it much more in detail and also was responsible for popularizing binocular indirect ophthalmoscopy with scleral indentation. And he has also invented a plethora of scleral buckles, which we use routinely even today, the solid silicon implants. So if I can break down scleral buckling into 4 major steps for understanding, these will be the 4 steps. Localizing the break, retinopexy, placement of a buckle with or without a band, and management of subretinal fluid. I use the word management because not always you need to remove the subretinal fluid. You can also leave the subretinal fluid, let it get absorbed if you have approximated the break to the RPE by a good buckle. So these are the 4 major steps. Even in the examination, if somebody asks what are the principles of scleral buckling procedure, you should mention these 4 steps, major steps. Then you can expand them. Okay, first step is what to localize. If there's a single break and relatively small break, if you localize the posterior tip of the break, it should be enough. But if it's a large break, you also localize the lateral horns of the break so that you make sure that your buckle supports the entire break and not just the central part of the buckle. If there are multiple breaks, you can localize, like you have seen in this drawing, assume that the dotted area is what you need to buckle. So to be able to encompass the entire area containing these 5 breaks, you localize the 2 extreme breaks and the posterior most break. Then that will cover the entire area that needs to be buckled. Breaks are in different quadrants. You need to decide first, am I going to put 2 buckles or 1 buckle? If you're going to put 2 buckles in a situation like this, you can always link it up with encircling band. Then you localize as marked in the pictures shown above. That is the 2 limits of the cluster of breaks. 1 cluster superior temporally and 1 inferior nasally. In a lattice degeneration, you can localize the 2 ends of the break and locate posterior most point of the break. Very often when the lattice is thin, you don't have to worry about the breadth of the lattice degeneration. There are multiple patches of lattice degeneration. You localize again, in this case, for example, the nasal edge of the upper lattice, lower edge of the temporal lattice, and also the anterior edge, because as you can see, they are not in one single circumferential line. They are actually haphazardly placed. So if you put a small buckle like a 276, you may buckle well the posterior lattice, but the anterior edge of the lattice may remain unbuckled. If that contains a break, it can be a cause for recurrence of detachment. So you should be able to identify points that need to be buckled. Even anteriorly, sometimes you may have to localize. Otherwise, usually you don't consider the anterior localization as important. The potential errors in localization are in a highly elevated detachment of retina. There can be issues of parallax, wherein you can probably locate the break more posterior than what it is, more anterior than what it is. Localizing under muscles also is very difficult sometimes because of the indentation cannot be seen if you're pressing over the muscle. So you understand that your localizing instrument should go underneath the muscle so that you can actually localize it correctly. If you have difficulty, you can always localize outside the muscle, and understanding that there's not exactly the break, but the break is roughly in that anterior posterior extent, but is located under the muscle. So when you have a confusion between indentation caused by the shaft versus the tip of the instrument, what you should do is move the instrument in its axis. Suppose you're using an indenter, like a forceps or a long indenter, and you think what you're seeing as an indentation inside the eye, you're not sure is caused by the shaft or the tip. If you move the instrument in its axis, the indentation you're seeing in the fundus also moves with the movement if the indentation is caused by the tip. But if the indentation is caused by the shaft, it does not move because it is still moving in its axis. That tells you that the indentation is not caused by the tip. Then you should move that indenter away from the sclera so that the shaft is not pressing the eyeball, but the tip is pressing on the eyeball. That is very important. Otherwise, you will localize wrongly the lesion, and then you will buckle in the wrong place. That leads to recurrence of detachment. So the order of steps for scleral buckling can be different. People use, in general, cryopexy. When you localize, of course, first, then you do cryopexy to the break. Then you place an explant with the suture. Then you drain if you have to drain. And after draining, you inject air if you have to inject air. So that is the sequence most people follow. But there is a technique called DACE technique. It's pronounced as DACE, not as DACE, because DACE intuitively become DAYS and not DACE. So it's pronounced as DACE technique. It's you drain first, then you inject air, and then you do cryopexy and explant. This is a very good technique when you're dealing with very bullous detachments where it's difficult to even localize the break. So you don't worry about localization first. You just drain. And once you drain, eye becomes very soft. So you don't want eye to become too soft. So as you drain, you must also inject air so that the eye is not soft. Otherwise, it can lead to subretinal suprachoroidal hemorrhage. And then once you inject air, then you can localize the break, do cryopexy and put an explant. The surgery is almost over. What are the advantages of draining first? Because the localization of lesion is very precise since the retina is almost reattached. And you're also draining in an area which is not treated previously by cryopexy, because you're going to treat only after you drain. Then the risk of subretinal bleed is less. But what are the disadvantages of draining first? Hypotony has to be addressed. Oh, sorry. Hypotony has to be addressed with intravitreal air urgently. Otherwise, you can have serious problems. And the air can get fragmented and can impede the view, and you may lose sight of the retinal breaks, especially if they are small. So maybe if you are in doubt that the small break can be missed, you try to localize the break first, even at least approximately, and then you drain. Complication of scleral buckling are intraoperative, early postoperative, and late postoperative. Intraoperative complications, you can damage the muscles. In fact, people have snapped even the muscles by violently pulling on the muscle. Vertex veins can be damaged even during tagging of the muscles. You can have accidental globe perforation while passing the sutures for the explant. Localization, as I told you already, can be inaccurate, in which case the buckle can be also inaccurate. Drainage-related complications can be a dry tap if you chose the wrong location, because for drainage, you need to locate where to drain. Ideal location is where the fluid is maximum. But given an opportunity to locate wherever we want, you would like to choose a site away from the vertex veins. So near the horizontal meridians is better rather than near the vertical meridians, because the vertex veins are closer to the superior rectus and inferior rectus. So staying away from the vertex veins gives you a less vascular choroid to penetrate, and hence less risk of subretinal hemorrhage. But if you have to choose between the highest point of detached retina versus staying away from the vertex vein, first priority is maximum fluid. Second priority is staying away from the vertex vein. Then you can get retinal incarceration. Again, retinal incarceration occurs very often because you chose a site where the fluid is less, or you try to you had a sudden gush of fluid coming out because your assistant did not relax the globe when you are trying to perforate. So when you are perforating the choroid, you must tell your assistant to relax the traction on the eyeball so that eyeball is not very hard. Because under high intraocular pressure, if you penetrate the globe, sudden gush of fluid comes, the retina follows the fluid jet and then gets incarcerated. Retinal incarceration itself is not very dangerous, but what is dangerous is it pulls on the retina beyond, and that leads to a retinal break remaining open. Or if the retinal incarceration is not recognized by you and you continue to pressurize the eye thinking that fluid is not coming, then the retina actually pops open. Retina can actually prolapse outside the choroidotomy and sclerotomy. Hypotonia related complications I have already alluded to, including subretinal hemorrhage and suprachoroidal hemorrhage, especially in a highly myopic eye. So you should go all out to avoid hypotony during drainage process and at the end of drainage process. Easier said than done, because it takes time for you to relieve, to get your hands free, even to inject air into the vitreous cavity. And by the time your hands are free, the eyeball is soft. So what you do routinely is ask your assistant to keep pressure on the eyeball while you prepare the syringe with the saline or air to inject into the vitreous cavity. You perforate the sclera, go through the pars plana, and as you're injecting, the assistant can release the pressure on the eye. So most important is never release the pressure on the eye till the eyeball is relatively not soft. I'm not saying the eyeball should be very hard, because you need space to tighten the sutures also, but it should not be very soft. And in selected cases where the fluid outflow is too much, you can even stage the drainage. Means you drain a little bit, inject some fluid and drain more, or tighten the buckle a little bit in another quadrant and again drain more. Fish mouthing is another important complication. In fish mouthing, what happens is large breaks, when you drain a lot of fluid and the buckle also is very high, it tends to open the break like a fish mouth. And this leads to a perpetual communication between the break and the posterior retina, even if the break is on the buckle. That's because there's a fold which is forming, which communicates between the open part of the break and the posterior retina. So this can be easily corrected by injecting just a bubble of gas or air, which presses the fold and flattens it against the buckle. You also simultaneously reduce the buckle height, because it is the height of the buckle sometimes which makes the retinal break open up like a fish mouth. And in some cases, you can extend the buckle a little posteriorly or place a small additional buckle, whatever called as Pruitt's implant, posterior to the existing buckle to reduce the fish mouthing phenomena. In most cases, you can manage it by these situations. And even if the fish mouthing doesn't look as if it is relieved on the table, Postoperatively, when you position the patient, the gas bubble goes over the break, it nicely smoothens the fold, and it no longer causes a problem. The early postoperative complications of scleral buckling are failure of retinal reattachment. The failure of retinal reattachment could be because you missed a retinal break, or it could be because of a new retinal break. It could be because of incorrect buckle-break relationship. The purpose of placing a buckle is so that you indent the eye wall against the break, so that the break settles on the buckle and is well supported. And the cryoatrophy or laser atrophy makes it a more firm closure. So if the break is not adequately supported, because of incorrect buckle-break relationship or fish mouthing, that can lead to a recurrence of detachment. Your break is well positioned, there is no fish mouthing, but the traction can keep the break open. That is because the vitreous traction is too much. Then, of course, you have to go in and do vitrectomy. Recurrent retinal detachment means there's a difference between persistent retinal detachment and recurrent retinal detachment. Persistent retinal detachment means your primary detachment itself is still persisting. That can be due to two reasons. It can be due to a persistent open break, or in a situation where there is no open break, all breaks are closed, fluid can still persist because it's a chronic detachment. There you don't get worried. The fluid may take time to resolve, slowly it gets absorbed. But as long as you are sure that the break is not open, then you have to will be patient. While young surgeons, novice surgeons are very much worried because the fluid is persisting, they're not sure whether the break is open or they missed a break or not. When in doubt, you should send this case, take an opinion from Dr. Lalit Verma. He'll tell you all breaks are sealed well, don't worry. This fluid will take time to get absorbed because it's lattice-related detachment. The fluid is very thick and viscous. It will take its own time to resolve. So in these cases, when there's thick fluid, you tend to drain always, even if the detachment is very shallow, because we know it takes a long time to resolve. And the residual fluid, just forget about it. After some time, you ask them to come back after 2-3 months. In fact, if you follow them up with OCT, you realize that it may take even up to 6 to 8 months for the subretinal space to become totally dry. Clinically, you think it's a dry subretinal space, but when you do OCT, you will find there's still fluid. So that is one situation, persistent detachment with a closed break situation. Persistent detachment with an open break situation, you have to correct it. You may have to adjust the break because of the buckle, because it's not covering the break properly, or inject a bubble of gas. These are simple ways of trying to correct the situation. Or in the worst case, go inside, do a vitrectomy and convert it into vitreoretinal procedure rather than an external procedure. This is persistent detachment. What about recurrent retinal detachment? This is a situation where the retina was fully reattached, at least for a brief period, if not for a long period. But then the retina got redetached. This can be due to a new retinal break, because if it is vitreous gel is still there, it can cause traction and cause a new break, or a reopened old break, or a new break caused by proliferative vitreoretinopathy. PVR is a real bugbear because that can redetach a nicely attached retina because of a puckering that effect that takes place, and the retina is pulled off in well buckled break. So PVR is an important cause for recurrence of detachment. The early postoperative complications also include serous choroidal detachment, which is not uncommon, especially in highly myopic eyes, aphakic eyes, pseudophakic eyes, etc. But that's not really a big problem. Serous choroidal detachment tends to settle down unless it leads to progressive inflammation and PVR. The choroidal detachment preoperatively present along with retinal detachment is more at risk of a postoperative PVR than a choroidal detachment which occurs postoperatively. Shallow choroidal detachment can settle down. In fact, large number of cases have a shallow choroidal edema, which is not clinically seen because you don't see it as a detachment of choroid. But if you see very often that the buccal effect looks very prominent the first few days after surgery, but the late postoperative it actually becomes less shallow, becomes shallower, not just because the buccal effect itself is reduced, but because the choroidal edema also is resolved. What about hemorrhagic choroidal detachments? They can be dangerous, but limited hemorrhagic choroidal detachment tend to resolve over a period of time, not leaving behind any residual damage. But massive hemorrhagic choroidal detachment can have breakthrough effects. The hemorrhage can break through the retina and cause the problems. This can occur intraoperatively as well as postoperatively. Secondary glaucoma can be because of a choroidal detachment. Even serous detachment can make the anterior chamber shallow by propelling the ciliary body process forwards, and this can lead to secondary angle occlusive glaucomas. You can also get secondary glaucoma because the gas bubble that you inject or the scleral buckle, if it is too high, it can cause anti-segment ischemia, and that can cause again secondary glaucoma. Anti-segment ischemia can have two ends of the spectrum. You can have cases presenting with secondary glaucoma or cases leading into hypotony, depending upon how much of ciliary body is insulted by the ischemia. Late complicated scleral buckling include buckle-related issues like exposed buckle, intruded buckle, infected buckle. Exposed and extruded buckle. An exposed buckle doesn't always mean it's infected. It can be exposed, but there may not be infection. Then sometimes you can get away by trying to cover it back with the conjunctiva, especially if the conjunctiva is retracted. But if the conjunctiva has got necrose over the buckle and hence the buckle is exposed, then it's very difficult to really cover it by trying to repair the conjunctiva by any plastic surgery. What you need to do is you need to excise the buckle at least in the area of exposure before you can bridge the gap by closing the conjunctiva. An infected buckle needs the entire buckle to be removed, including all the sutures. An intruded buckle is a lot more difficult to manage because an intruded buckle, even while exposing, can lead to scleral rupture, a globe rupture. So as long as the intruded buckle is not infected or not causing problems, we try to leave it alone. If you have to remove it, you have to be really prepared for repairing a scleral globe rupture by having a scleral graft material with you. Strabismus and motility restrictions can occur because the handled muscle tends to get stuck to the sclera. So the more the muscle handling, the more the risk of induced strabismus, and hence you should always let your assistant not keep on pulling the globe when you're not requiring exposure of the posterior part of the sclera. You should tell them to relax when you're preparing the needle holder with the needle. They should not be keeping on pulling and exposing the sclera unnecessarily. Only when you have to actually pass the suture, you need to ask them to pull on the sclera. So unless you handle the muscles, the eyeball remains very quiet postoperatively rather than something which is handled too much. Relatively unimportant side effects are induced myopia, foveal displacement, and some degree of enophthalmos caused by orbital atrophy caused by the handling. A word about temporary buckles. Balloon temporary buckle has come and gone. Nobody is using it these days. It was popularized by Harvey Linkoff. And suprachoroidal buckle, some people still try. Now, of course, they are using it for a macular hole rather than for the peripheral breaks, where you inject sodium hyaluronate in the suprachoroidal space. So last slide is a good prognosticating factors are short duration of detachment, an attached status of macula, or a macula which is detached for not more than few days. People have seen that beyond a week, the visual recovery is less. So less than a week, the chances of good recovery is still there over a period of 5 to 6 months. They can cut back 6x6 vision. Absence of other complicated issues such as a GRT, macula hole, etc. Absence of PVR, absence of intraoperative and postoperative complications. So in general, 90% of fresh, uncomplicated detachment of retina can be attached by a single surgery. This is a very important message to for the youngsters, because if they want to benchmark themselves against what is supposed to be the ideal, they should aim at a 90% success rate of a fresh detachments of retina. So in conclusion, retinal detachment is the separation of neurosensory retina from underlying retinopeptide epithelium. It's caused by presence of retinal breaks. A fresh detachment has a very typical appearance which is unmistakable with corrugations, and they're diagnostic even if a break is not itself visible. So by looking at the detachment, you know it is RRD, and then you actually look for a break. Finding and closing all, I underline the word all, retinal breaks is the approach to fix a detached retina. Scleral buckling is an external approach aimed at indenting the eye wall inwards against the vitreous gel, while vitrectomy aims at removing the vitreous gel, and pneumatic retinopexy is also an internal approach, although it is not removing the vitreous gel. If pneumatic retinopexy is successful in selected cases, and hence, if case selection is bad, failure rate will be high. Part-spanner vitrectomy approach is more and more preferred now, or scleral buckling, even for fresh detachments of retina, especially in pseudophakic eyes or large retinal breaks. Scleral buckling would still be preferred for RRD, secondary to lattice degeneration with atrophic holes and for retinal dialysis. These are two indications where I would believe that scleral buckling still is the most important first treatment of choice. Thank you very much for your patient hearing. I think I overstepped by about 5 minutes. So the
No, sir. No, I think time is on our side. There's no issue about that. I think Dr. LG has very nicely covered this topic of buckling and pneumoretinopexy. And initial couple of slides also explained the various factors which keep the retina attached. The 5-6 slides, those are very, very important to learn that how this retina is normally attached. And very important thing, he emphasized a lot of slides on complications, how to manage them and how to prevent them also. Do we have any questions? Because first priority is to answer questions by the people who are in the hot seats. We can stop sharing, LG, sir.
Yeah.
So let me read out a couple of questions which are there. One question is that what is the reason for most common presentation of detachment in the supratemporal quadrant?
It's mainly because the breaks are also commonly seen superiortemporally because there are stronger vitreoretinal attachments in that quadrant, and hence you'll get breaks in supratemporal quadrant. Otherwise, there's nothing specific about supratemporal quadrant. You can get breaks anywhere else also, but just that if the anomalous vitreoretinal attachments are more in the supratemporal quadrant, you may get more breaks and more detachments. But inferior detachments are also seen quite commonly.
Other question which is related to one of your slides, which said that in case you have multiple holes in different quadrants, one slide you showed where supratemporal influenza breaks were there. So question being asked is, if multiple quadrant breaks are there and 2 buckles are being planned, will it lead to more complications?
Not really. You can put 2 buckles and then you also have an encerclage to keep the buckles in place. So I didn't elaborate on the role of encerclage because the time doesn't permit that. But basically the encerclage tries to keep the buckles in place. And when you put two buckles instead of 1 buckle, then if you replace the 2 buckles by 1 buckle, it has to be an unnecessarily large buckle. A large segment of the buckle is doing no useful job because your breaks clustered nicely in 2 separate quadrants. You can place 2 buckles and link it up with the encerclage. I don't think it increases the complication. In fact, it reduces the amount of explant material you're placing in the orbit.
Generally, if they are close by, we may put a larger extent of 1 buckle also.
Yes.
And in such situation, if they are very far away, then only you think of small pieces. And generally in such patients, encircling element is a must. There's one more question I saw. Let me see. What is the maximum time period to observe the patient with scleral buckle or retinal reattachment? I think the question being asked is about the persistent fluid.
Okay. So as I alluded to, if there's persistent fluid, first thing to do is to check what is the cause, whether the break is closed or not. If you're in doubt, as I said, I don't mind taking an opinion from my peers or seniors, somebody who is working with you to make sure that you're not missing any break. So repeated detailed examinations to make sure that there is no open break. If there's no open break, you're just waiting observing for some time. Suppose you observe for a reasonable period of time and still the fluid is persistent, then it's likely that you are not able to see the tiny break. This happens very often in highly myopic eyes, where even a thin film of vitreous membrane can obscure a tiny break, which is in the atrophic areas. So when in such doubt, if peripherally there is no open break, you have to go in and do vitrectomy, because only then you can identify these tiny breaks which are hidden in the posterior pole and the atrophic areas are covered by a flimsy membrane. So when in doubt, you have to go inside, no choice.
So Dr. Soini, there's no maximum time period. Only thing is the vertical time course which will tell you. If the fluid is like LG was saying, it's best to monitor these patients either by NDET or by referral via OCT also. If the fluid keeps decreasing all the time, then you are a happy, happy patient is happy and you are also happy. But if not, then follow what Dr. LG was saying. But believe me, it sometimes takes months, 6 months to 1 year also, for sometimes, this fluid to get absorbed. As long as it is, progressively decreasing, so don't worry much about it. Obviously, rule out, any missed break or any especially in high myopic, tiny small holes may be there, which require, very, very careful observation. So any other questions?
We are not confusing here between a bullous persistent RD versus shallow RD. So what all we discuss now is for about shallow RD. Where bullous RD persisting, obvious that there is a break which is missed, or the break is not buckled properly. Then if you can't see it, you have to go in and operate very early. We don't wait for months together for such cases.
Yeah, rightly said. Any other questions we have?
So there's one question which is generally about pump-nodding agents. I think so has already explained it and also mentioned in his conclusion. But if they asked if you had to summarize, how would you decide the pump-nodding agent, which agent in what condition? What are the intraoperative and postoperative factors you would consider to decide the agent? And also, what is the positioning in each agent?
I don't understand. Is it tamponading agent after vitrectomy you're talking about? Or are you talking about pneumatic retinopexy?
Silicon oil, air,
I don't think my topic is covering that at all. That's why I didn't.
Only thing which we can maybe have choice between SF6 vis-a-vis C3F8.
Yeah.
That could be only related to this talk. Otherwise, you see, that will require another discussion about after vitrectomy, whether oil versus gas. That's a very different subject.
Yeah, totally different.
But could you please tell about SF6 vis-a-vis C3F8?
I think I generally try to use C3F8 because you can inject a smaller gas quantity and not have a rise in intraocular pressure and have the same effect because it expands much more than SF6. But if you don't have access, you can always use SF6 because that you have to inject 0.5 cc. Otherwise, it won't acquire the required volume. So in general, I try to prefer C3F8.
So Deepti or Rolika, any other question in any other channel?
So somebody has asked, what are the rules for air travel after pneumatic retinopexy?
Yeah, I think we should remember that the gas, when you're using pure gas, it expands much more in the eye. But once the gas is there in already, because patient would have been there with you for about a week or 10 days before he wants to fly. By that time, the gas expansion phase is gone. Now it's mostly sort of a resolving phase. So then it behaves like any other air or gas, which is residually present in the eye. Although many studies have shown that a gas bubble which is less than 1/8 the capacity of the vitreous cavity may not cause problems in the air travel. I've had personal experience of 2 patients who had shared with us that even a small gas bubble can, at very high altitudes of 30,000 feet and all that, which is international travel, can expand enough to cause even a sentinel artery occlusion in a patient who is already having a compromised circulation of the optic disc. And in fact, this patient became NPL from 6/9. And only when the flight landed, he again got back his vision. So it's very important that if you are sending a patient by flight, it's best to tap the residual gas before you send them off. If they cannot stay until the gas gets absorbed. Even if it's a small gas bubble, I would prefer that they don't fly based upon this experience.
So meaning thereby, till the time gas is there, you will advocate not to fly, because even small bubble. I also have the fortune or misfortune to see one patient who actually permanently lost his vision. He was traveling from Singapore only, and record there showed very good vision. But when he landed, and he came after a couple of weeks to ask me, and he had NPL vision because of CRA block. So Deepti, any more?
So maybe we can take one last question. Somebody's asked, how do you manage buccal infection?
Yeah, I think there are 2 ways of looking about it. The early postoperative period, sometimes you find that the buccal area is tender and patient is continuously uncomfortable. We are never sure whether there is subclinical kind of infection without abscess formation and all that. So we tend to give antibiotics, sometimes they become all right. So I'm not sure whether there's really that kind of infection or it was just that the inflammation is taking time to resolve. But what we're talking about, a buccal infection, is something which is usually a little later, and then you have a frank exposure of the buccal with purulent material stuck to it. That will never resolve unless you remove the entire explant material. So you have to expose the whole conjunctiva and remove all buccal and extraalloplastic material, only then gets cured completely. So infected buccal, although some people try to treat them with antibiotics, you may buy a little time, but ultimately you will need to remove the buccal.
So Deepti, the answer is by and large you have to remove these buccals, especially if these patients have mucopollulant discharge with a big gap in the conjunctiva. You can't keep observing and keep treating with recurrent course of antibiotics and all. That's not a good technique. I know some patients have that fear instilled in the minds of these patients that there may be a redetachment. But believe me, most of these patients do not develop redetachment unless it's very early, which does not happen. Majority of these patients, by the time they come, the retina is firmly attached. It's primarily, bad suturing or some issues which have led to these issues of bacteria having a ingress into that space and then causing those issues. It is always better to remove these buccals and if possible take a large bites and try to oppose the conjunctiva. The conjunctiva is necrotic, so they should take large bites and try to oppose as much as you can and irrigate that area with the antibiotics. So LG, I had a couple of things to just ask. Of late, you said in the last slide, the buccal, younger people are hardly using buccals, whether it's a phakic eye, pseudophakic eye, even if it's a buccalable, detachment, they will like to go in and do rather than. So, what is your comment on that?
No, I think I must say that even my own practice has changed over a period of last 10 years. And the cases which I would have definitely buckled 10 years back, I probably can do a vitrectomy now, a primary vitrectomy. So the exceptions are that, as I said, if pseudophakic RDs, I almost always do a primary vitrectomy.
Yeah.
I rarely do a primary buccal. And if it is a phakic patient, sometimes you do buccal and sometimes you do a vitrectomy depending upon number of breaks. If there are multiple breaks or large breaks, then you go in rather than try to buccal. I may add an encircling band, but I'll also go in. But if it's only buccal, probably I may not do. But if you have a lattice with holes, atrophic holes, and a chronic RD, even if there is some amount of subretinal gliosis, I'll prefer a buccal.
Yeah.
And bring the fluid because they do extremely
young phakic patient,
yes.
Multiple demarcation lines, that is generally an indication of buccal rather than
buccal rather than vitrectomy. Likewise, the dialysis is a different indication for a buccal rather than a vitrectomy. They do extract very well with just a buccal, and because even there the vitreous gel need not be separated well, so they will do well with buccal.
The last thing which I had in my mind was that role of PR pneumoretinopexy, since it was described or popularized by Hilton long time back, has actually decreased quite a bit, and people rarely use because of multiple issues, because I think they can go inside and operate in that short time rather than depending on pneumoretinopexy and then post-op inferior PVR occurring and new break formation in the inferior part. So what is the current status and how many times?
I think it has probably gone out of vogue because of many reasons. Yeah. People sometimes burn their fingers because they chose the wrong case, and then they say, okay, pneumatic doesn't work, so they don't want to go back to it. Or, like as you said, the vitrectomy is become a very good option now because it is more elegant and 100% you can treat all the breaks, and it's not like in the era of the 20 gauge vitrectomies and with no wide angle system where we had a lot of difficulties, and hence pneumatic retinopexy was not a bad option at the time. But now with a good vitrectomy with a wide angle system and 25 gauge instruments, vitrectomy is not a bad option either. So hence people try to choose a more definitive procedure to a procedure which has got a little risk of recurrence of detachment. So that's the one reason why, not because pneumatic retinopexy per se is a bad technique. It's just that we've got probably techniques which are much more definitive in their outcome, and hence you do it.
Yeah, honestly speaking, primary pneumoretinopexy, it has been now years that I have done that. When it came, we used to do it, especially in bullous RD or fresh, obviously with the criteria which you mentioned. So, but of late, because of the ease of doing, the microincision vitreous surgery, And in a short time, I think you achieve very dramatic results compared to doing pneumo and then hoping that it will, do good and not yield to any other
I
complications.
think two situations where I will use pneumatic retinopexy is one, somebody who is sick and they are not able to go through a surgery, and then you try to take a chance by doing pneumatic retinopexy. I've had just 2 or 3 patients who are undergoing chemotherapy and they're now not able to undergo surgery, and I could fix the retina by pneumatic retinopexy. Second situation, as you said, is secondary pneumatic, not primary, where the buckle is placed but not succeeded. You can inject a bubble of gas and get away with it.
Yeah. So I think the time now is not on site. We normally try to finish right on time, 8 to 9. And must thank on behalf of entire CFS team, thank LG for covering this topic very, very well, because nowadays people jump to VR procedure immediately and forget this, the technique and nuances of scleral buckling, which LG has explained very, very nicely. So we conclude by saying scleral buckling not dead today, as long as you know when to do it and how to do it and how to avoid and prevent all these complications. Like LG just hinted, that in a young patient, phakic patient, in a dialysis or lattice with atrophic holes, even though there may be multiple subretinal bands, choice would be scleral buckle in such situations. So with this, I think we thank Dr. LG for making this job very, very simple and for us to comprehend and learn this art and technique of scleral buckling.
I would like to use the opportunity to thank again Dr. Santosh, Dr. Lalit, and the entire team in iFocus for this opportunity. Thank you. You're doing a great job. So please keep it up. Thank you very much.
Thank you. Santosh, any announcement? Yeah.
Okay, LG was the one who did the opening lecture for our first iFocus. So I think.
Yeah.
Thank you.
Bye.
Thanks a lot. Yeah. Yes, Malika.
We have pathogenesis and management of proliferative vitreal retinopathy by Dr. Aniruddha.
So then now we'll be entering into the vitreous cavity now. Thanks a lot. Thank you, everybody. And
Thank you so much.
bye-bye.